Hello to everyone listening. I'm Dr. Uma Ali. I'm a pediatric nephrologist. I've been practicing pediatric nephrology for almost 40 years now. And I'm currently affiliated to Leelavati Hospital for Children Hospital at Mumbai and SRCC Children's Hospital also at Mumbai. What we're going to talk about today is the privileges that children require when they have chronic kidney disease. Now, to understand what's chronic kidney disease, it's very simple. Any kidney disease which does not get fully resolved in 3 months' time, we call it chronic. But it does not mean that every child who's labeled chronic kidney disease will progress to kidney failure. But a subset of these children who have chronic kidney disease over time may progress, depending on the underlying disease and its response to treatment, may progress over time with decreasing kidney function. And when this kidney function becomes less than 20% of normal, we call it end-stage kidney disease. We call it end-stage kidney disease because now the kidney cannot sustain itself with just medicines, and it needs additional support, different kinds of treatment, which ideally would be kidney transplantation. And in the interim, while we are awaiting kidney transplantation, if there is a delay in getting the transplant, then it would be dialysis. So when the child's kidney function reaches a stage which is so low that the child cannot survive for long without a kidney transplantation or dialysis, we call it end-stage kidney disease. Now, increasingly, what we are seeing is more and more children coming with chronic kidney disease with less kidney function and who slowly progress to end-stage kidney disease. Now, this is, say, much more than what I would have seen, say, 20 years ago. And there are many reasons to it. One is there are more pediatric nephrologists in the country now. 20 years ago, there were just a handful. Today, there are more than 200 pediatric nephrologists. So there are multiple centers across the country where children with such problems can be handled. And so the referrals are more. There's also increased awareness in pediatricians who look after these children primarily about kidney disease and how to recognize it, when to refer, etc. So that is another reason why we see more. And third, a very important one is that most pregnancies in most places, there is an ultrasound done during pregnancy. And this detects many kidney abnormalities in the unborn child. Now, all these kidney abnormalities don't become chronic and don't go to kidney failure. In fact, majority, 80% of them would not go into kidney failure. They can be managed well. But a segment of these would progress to kidney failure. So they can be picked up even before they are born and followed up and treated early so that you can delay this progression or prevent this progression from birth itself. There may be a true increase in the incidence of chronic kidney disease because you have a very advanced now neonatal care. So many newborn children, premature children who would not have survived earlier are now surviving. But sometimes these kidneys are not very well-developed kidneys. They've also faced a lot of stress during the NICU stay. So over several years, some of these children, not all of them, but some of them will go into kidney failure. Similarly, you have very excellent pediatric intensive care units now. So many children with critical illnesses do survive. So many of them develop some kidney injury during the critical illness, which resolves initially, but some of them in the long term may go into kidney failure. And cancer survivors similarly have a problem because some of the chemotherapies we use may be toxic to the kidney. And there's widespread use and misuse of many drugs, both allopathy and non-allopathy, which can be harmful to the kidney. And these in India are available over the counter and often self-medicated or given by parents, which can have a toxic effect on the kidney. So there may be both a true rise in incidence as well as earlier recognition which has led to the increased number of children being detected with end-stage kidney disease. Unfortunately, we do not yet have national data of how many children do we have in India who are facing end-stage kidney disease, and how many of them really receive dialysis or transplant, and what happens to them. We are right now, the Indian Society of Pediatric Nephrology has just initiated this year a national registry to record these events. So at some point in future, we may have a clearer idea, but just a extrapolation from what we know in Western countries. The incidence of end-stage kidney disease in children is anywhere from 15 to up to 60, 70 per million population. Now, converting that, we would say that in Maharashtra alone, we may have somewhere between, you could say, in 1,500 to 3,000 children who have end-stage kidney disease. And in the whole of India, this may be 25 to 50,000 or more. This is a very, very rough guess. Now, I can give you an idea of how many children in Maharashtra actually are receiving dialysis and transplantation, because we tried to find this out some time ago. And it looks like not more than 150 children out of the 1,500 or 3,000 who need it, hardly 10%, 150 children are receiving dialysis or have undergone transplantation in a year, at a particular year. So the numbers who are actually getting the treatment itself are very few. And there are many, many problems we face while trying to deliver this therapy to children. Because what can we offer when a child goes into end-stage kidney disease and the kidney cannot sustain itself and the child would die if we don't offer some better therapy? The best therapy we can give is kidney transplantation. So when we give a new kidney to a child, any adult who's healthy, who has 2 healthy kidneys, who does not have any heart, liver disease, these all tested before transplant, can very safely donate 1 kidney, because we do not need 2 kidneys to survive. Many people are born with a single kidney, but they survive to 70, 80 years without having any problem, as long as the kidney which is present is a healthy kidney and they follow a reasonably healthy lifestyle. So that is the basis why a living adult can donate a kidney to another person. But the gaps we get in this, one is that there has to be a compatible blood group. Just like your blood transfusion, you cannot give any blood group to any person. It has to be a blood group which is the same one or which is compatible with the patient. So that is a primary requirement. And the donor's health is an important thing, because we cannot put the donor's life at risk or health at risk. So it has to be a healthy donor. So many times when we investigate, although the person may seem healthy from outside, we may detect problems not detected earlier, like diabetes, high blood pressure, cardiac problems, liver problems, etc., or infections, which make them unfit to be a donor. So in spite, and it's the reality is that parents may not have the same blood group as the child. This may sound surprising for some people, but parents may have entirely different blood group from their child and may not be really in a position to donate, even though they may want to donate to their child. So many children, even though the parents may be willing, may not be able to receive a kidney from their parents because of these factors. Blood group heads the list, and the donor's health factors, as I mentioned, diabetes, high blood pressure, liver, cardiac disease, viral infections, which may be detected on testing. All these become barriers for them to donate the kidney. For such children, what is the option? Okay. Now, if we pursue the transplant path, supposing the parents are healthy, but their blood group is not compatible, we can do what is called an ABO incompatible transplant. That means the blood groups are different, but we can still transplant and make the patient's body accept that kidney by treating the patient in advance before the transplant for 2 to 4 weeks with very focused with therapy, which makes it a very expensive process, because whatever is your transplant cost, this is going to multiply that cost at least by 1.5 times, if not more. Second, some of these therapies themselves are slightly toxic, so that exposes the child again to more toxicity than he would if he was getting a plain ABO compatible transplant. And there is slightly higher increased risk of rejection than if you have a compatible blood group. Your risk of rejection today is very low. You would have only less than 5% risk of rejection in the first year with a compatible transplant, whereas with the ABO, that risk may be a little higher to 10 to 15%, and sometimes maybe even 20%. So there are many issues why we may not be always able to offer an ABO incompatible transplant. The chief amongst that is, one, the capability of the transplant unit to handle that. And I think even more important is the cost factor which comes in, because transplant as it is a slightly expensive option. And so when you do an ABO incompatible transplant, it becomes even costlier with little added risks. So if a child does not have a suitable live donor, the option for the child is get a kidney from a deceased donor. That means somebody who has died due to an accident or some sudden event, and who is now what we call brain dead, that his brain is not revivable, it is totally gone. Such a patient can donate their kidney and their other organs to anybody who needs it. And this is called deceased donor transplantation. But this cadaveric donor transplantation is governed by various laws which have been thought out and periodically streamlined. And it is a list which is with the Zonal Transplant Coordinator Center, which is set up by the government, so that all the people who need a cadaveric donor, cadaveric kidney or cadaveric organ, can get themselves registered there. And so it will go numerically as a first come, first serve process for each different blood group. So A, B, O, AB are classified separately into 4 groups, and each group has a number from 1 to whatever number is there. At present, there is no clear priority for children to be higher on the list. So the average waiting time for a cadaveric transplant is very low. If you are lucky, it depends on which state you are, where you are, etc., because the strength of these programs also vary in India from state to state. But say if you're in Maharashtra, the average waiting period for a cadaveric transplant is approximately 5 years, if I take the average. There have been few patients who've been lucky enough to get up within 1 year of waiting or 1.5 years of waiting, etc. But most people have had to wait for very long. So I'll give you an example. And during that time, what they can opt for is only dialysis, because they've already reached a stage where they cannot carry on without transplant or dialysis. Transplant is not feasible, no living donor feasible. So the only option is dialysis. Now, dialysis in children is not so easy as dialysis in adults. Okay? There are many dialysis centers for adults. Even in small district places, you would have a dialysis center where they can handle 15 to 20 adults, and which are looked after by the dialysis technicians with an adult nephrologist visiting the center periodically and not really being there all the while. This cannot be done for children. Okay, children, if they need hemodialysis, which has to be done, it has to be based in a hospital where there is a pediatric nephrologist, because children may have many ups and downs during dialysis, and they would need immediate attention by a nephrologist or a doctor in attendance to take care of those problems. So it has to be hospital-based. It has to have a pediatric nephrologist. As I said, there are only 200 pediatric nephrologists in India for 400 million children. Luckily, all those 400 million do not have kidney disease. But majority of them are practicing in metropolitan cities. So the moment you step out of a tier 1 city, the number drops dramatically. So I'll give you an example. In Mumbai, we are now 30 pediatric nephrologists. You move out to Pune, you come down to 5. You go down to Aurangabad, there's 1. You go to Nagpur, there is 1. You go to Dhule, there is none. So on and so forth. So the more you move away, you find there is no pediatric nephrology service. And children are not just small adults. They have a number of issues which need somebody trained in pediatric nephrology to care for it, especially children on dialysis. Besides not having the required doctors, technicians and nurses trained in pediatric dialysis are even more scarce. And it's very difficult to get, a fistula made for a small child. So they have to have catheters put in their big neck veins. And the care of these catheters has to be very, very stringent. If you don't take care of the catheter well, you'll get an infection. And it's not an exaggeration to say that many children who are getting hemodialysis outside pediatric nephrology institutes die of infection. This is not an exaggeration. Okay? Or they acquire viral infections like hepatitis B, hepatitis C, because the overall asepsis requirement, etc., for the dialysis unit is not up to the mark. So that will hamper their subsequent chances of getting a good transplant. So there are a number of issues why hemodialysis is for smaller children who are below 12, 13 years is not really available except in few major pediatric nephrology centers. So the second type of dialysis which you have is what we call CAPD, where we put a catheter inside the abdomen. And this can be done at home because it's like a stomach wash. Fluid is put in the abdomen and drained out. It's simple. It's not difficult to do. So this can be done even by a patient who's living far away from a big city. But 3-4 issues again. They would require periodic checkup by a pediatric nephrologist. So there has to be access to that. There has to be access to somebody trained in managing CAPD complications because they can get infections, sometimes catheter problems, and those are emergencies. And third is the cost. Okay, it is expensive. CAPD is not cheap and it's expensive. And as of now, there is no particular relief from the government in terms of, taking off the tax from CAPD or making it free for children below 5 years or 7 years, because it's a lifeline for them. But as of now, there is no such options available for children. So many parents opt not to do because it's too expensive and it's not easily manageable if they're outside a major city. They have to struggle for many things. When I was working before my retirement at Baijar Bhai Wadia Hospital Children, which is a premier children's hospital and the first one of its kind catering for underprivileged children, we had a patient who was staying some village away from Satara, and he was traveling almost 400 kilometers for coming for follow-up. And that child we put on CAPD because both parents had different blood groups. She was registered for cadaveric. But the cadaveric took a long time. And every time the child had a catheter problem, this man took the PD bag, sat in an ST bus, traveled overnight for 12 hours with a sick child. And it was just God's grace that the child didn't die on the way to the hospital. Luckily each time we could treat her and get her out of it, but the father didn't give up. And this he kept on for 5 years, and she finally got a cadaveric transplant some 7 or 8 years ago. Now she's a young adult doing well. But the point I'm trying to make is the difficulties the parents go through. Okay? This father had to leave everything and bring by ST bus, travel nearly 400 kilometers just to treat the infection in the peritoneal dialysis, because there was nobody else to do it there. And the cost he must have spent, although the hospital didn't charge him, but for the peritoneal dialysis cost, the travel, loss of wages, must have been enormous. So there is a huge problem in implementing this. Now, even assuming we can implement all this well, which I don't see as something which is happening in the next 5 years, we have other issues, because dialysis is not a perfect answer. It gives you 20% of your kidney function. The remaining functions have to be supported by medications, by injections to improve your hemoglobin, not allow you to have bony deformities, allow you to lead a healthy life, etc. Now, if the child is coming for hemodialysis to a center or to a hospital 3 times a week, plus taking this medication, so one parent has to accompany this child. So the parent loses wages on that day. The child's schooling is at jeopardy, because how's the child going to go to school if thrice a week is coming for hemodialysis? And the cost of travel and other incidental costs, which we are not counting in the dialysis costs, which is itself expensive. Schooling goes for a toss. There's no recreation play activity for those children who manage to go to school, like pediatric centers like ours at SRCC and Vadia Hospital. We try to accommodate the school hours and try to get them different hours for dialysis. But if they're taking dialysis in a busy adult center, it is just not possible for them to adjust their timings for the children because they're overfull. So schooling itself is something which you have to keep in mind. Play, nobody thinks about. A child's life becomes very psychologically damaged if they don't have friends, if they don't play. So that is another. And most important of everything is the growth. When you have chronic kidney disease as a child, your growth is affected, your height is affected. Now, even if everything else we keep well and manage the weight, the height always takes a beating. And to improve the height, you need growth hormone, which is exorbitantly expensive. So there is hardly any, very few Indian children with kidney disease who take growth hormone. So majority of them are much shorter than the others. Now, if during this time they're waiting for transplant for 5-6 years on cadaveric transplant, they lose all their growth years. And once their growth years have passed, even if they get a transplant, they are going to remain very short adults. So this also has a lot of social kind of impact of the lives they lead, their own perception of themselves, and various other issues that arise secondary to this. So if you look at all this, as it stands now, dialysis is like a life-saving, no other option. So we do dialysis. Okay. So our better option is transplant. So if there is no live donor transplant, then children need to be given these special privileges. They need to be high on the list of transplant, which is there in many countries, that, children are given a higher number always, so that if a kidney becomes available and a child is on the list, they get priority. Because the child does not have time. If 5 years of his life he's going to spend in dialysis, he or she has lost a lot on the way, which can never be given back to them. So this prioritization is needed, and to make it somewhat equitable so that we don't deprive adults as well who need it. Maybe one suggestion which is there is that every child who needs a transplant, the parent should be by default check And if the parents are not suitable, only then they should be entered for cadaveric transplant. So we don't fill it in with people where they have a parent who can donate. So where there is a parent who can donate, that should take priority. And for those who do not have a suitable parent because of blood group or ill health problem, should be put on the cadaveric list. And that cadaveric list should prioritize children. That children should be high up on the list so that the waiting period gets as minimized as possible. Because of all the issues I said about dialysis in children. Okay? I'll just end with two examples. Now, I have a patient who's now 14 years old. He was diagnosed with end-stage kidney disease when he was about 8 years. And it was already very advanced because it was a missed diagnosis. So he was already in end-stage kidney disease when I first saw him, and he has been in dialysis since then. Now, he's a very active boy, and he likes to play football. So he goes, he's very active after dialysis. He goes, he plays football, he goes to school, he attends his school regularly. But he takes his dialysis from a catheter which is put into his vein. And he has had at least 2 major catheter infections where he had life-threatening sepsis requiring ICU stay. So I won't even count the cost of that in money, but the cost it may have cost him his life. Now, he was registered for cadaveric donor because both his parents are unsuitable. Both of them are diabetic, both of them are hypertensive, so he didn't have a suitable family donor. Almost 5.5 years or close to 6 years from the time he was registered, he's still not got a kidney. And so now his aunt, who is ABO not compatible, has come forward to donate her kidney to him. So we will be going ahead with an ABO incompatible transplant because parents have accepted the cost because now the child is 14 years, they don't want to wait any longer. And during the lockdown, the cadaveric whole program has taken a beating, and so the chances of their getting has become even less. So we are going ahead with that, with the understanding of the increased cost, etc. Okay. So this, and there have been other children who, while waiting for dialysis, have not been so lucky, who are taking dialysis maybe from other places or here, who have had some major infection or catastrophe and have unfortunately died while waiting for dialysis. So you have a number of issues, and then there are a couple of children who are taking somewhere in other cities and small towns, and they've either acquired hepatitis B infection, which makes a subsequent transplant a challenge, hepatitis C infection, which would require further treatment before the transplant, etc. So putting a child on dialysis is not our first option. It is our last option. So we need to improve the other options for these children, like going for live donor transplant, compatible transplant, cadaveric transplant, by improving their chances for being higher up, which is something which a government needs to take note of. And some of the other privileges beyond transplant which we need is for dialysis. I think pediatric dialysis by default should be made free by the government because it's a lifeline for these children. Especially CAPD, because that's the only thing possible if the child is very small, below 5 years. Hemodialysis you cannot do. It's the only feasibility if the child is living outside a major city which does not have a pediatric nephrology center. Then they should not even risk hemodialysis. They should go for CAPD. And unless CAPD is made free for young children, it's not going to happen. And we are going to be in the same phase what we are, where hardly 10% of the children who need this treatment are getting this treatment today.